Let's put it on record. Week 9, guys. It's just amazing how quickly time goes by. As I told you, and as I warned you, it gets really rough in the end. Everything comes up on you, everything's due, you get confused. I don't know, I don't remember. I've had students say, hey, I forgot that discussion question. Get it in by Sunday if it's any of you. Now, the project that was due last Sunday, there's still some that I have send back rebuttals where if you don't see a decent grade, or even if it's above 80 in that 80-90 area, go back and look at comments. I might have told you, put references on your teaching. I might have put, you need this or that, or something to your assessment, do this. I will increase your grade, but only till this Sunday. So make sure you go back and you look at your patient assessment, your pediatric assessment assignment, okay? I've been really spending a lot of time reading them. I was just talking to Brent about his because it was an unusual assignment and he really described it well. So I had a feeling it was personal and he just, yeah, it was. So that was really cool. So thank you everybody who shared something very personal from their family, their children, you, whoever. So I really appreciate them, and I do look over them very, very closely. So they're all graded, as I said. If you see a lower grade, please look at my little messages to you, my comments, return it, and let me know that you've returned it. It's 75 students, so it's hard for me to go student by student to see who has sent it back. So if you have given me something back, send me a message in Canvas or email, whatever you want, because I want you to get the best grades. That is 6% of your subjective grade. And I know students who've not done well on that assignment and were borderline an 80-ish, on the overall KGA, or your average at this time, they were close to failing. So don't do that to yourself. It is a large portion of your grade, okay? So now that I've gone through that. So today we're going over musculoskeletal, articular dysfunction, neuromuscular, and muscular dysfunction. And these are chapters 48, 49. There is Kaplan math due this week. I'm going to tell you, I'm not going to grade it this week. I'm going to grade it when pediatric A, B, and C are done. Okay, remember to remediate everything you do, every question, because I have to go each campus, each student, look under each one and make sure you've done it. So I'm going to do it once. I'm not doing it twice. I'm a little busy, so I won't do that to myself. So I'm giving you the grace and I'm being honest. And that's, you can tell with me, I'm just honest to a fault. Remember, there is a discussion question due. If you haven't done it, okay, I get it. It's week 9. There's too much going on right now. You just had community tests and now you're going in, or another test somewhere, and now now starting to prepare for pediatrics. Now, last night, there was a review by Professor Morris. It didn't record. So you will not have a Professor Morris review, okay? You will get mine on Friday at 2 p.m. and you will get Professor Okorafor's on Saturday at 6 p.m. Those will be sent to you. I'm also, as I send out your this week's recording, I'm setting up the review email announcement that I send you, and I'm putting all the Kahoots all in one place so you don't have to look all over, because I know 3 courses, announcements all over the place, you're not going to find them. So I put it one place to keep you guys, put together. Any questions? Okie doke. So let's start with our PowerPoint, and then we're going to go into our Kahoots. Kahoots is a little bit shorter than usual, but it's still 39, 40 questions, I think. There we go. So, musculoskeletal dysfunction. Now, I tried to put a lot of pictures here so that you could see what I'm talking about. Cast and crutches, that. That little baby up there has something called a Pavlik harness on. It's for hip dysplasia. And I'm gonna, go over it more as I go through that. The one on the bottom is called Buck's traction. And what I want you to see from this picture is something's pulling the leg skin. It's not skeletal. It pulls the leg, it goes over a bar or a pulley, and there's weights that hang. And the thing about those weights hanging is they must be free, not on the floor, and 24 hours a day, never take them off. And we're going to go into all those reasons, but these were great pictures I had to show you. So a mobilized child, does it matter if we're mobilized, a child or adult? No, but let's go into the child. So sometimes children are immobilized because of congenital defects. I'm going to go into something called osteogenesis imperfecta. These children have brittle bones and, most of them never walk, okay? Some degenerative orders where maybe they could have walked, but their muscles degenerate and atrophy away. Infections, injuries that impair the skin, that can cause a child to be put down in bed for quite a bit of time for healing. And then we know with any immobilized child, adult, there needs to be therapies. Some get physical therapy, occupational therapy, to help keep those muscles strong, and some can't have it. So the muscular system, we know you're going to see foot drop. You're going to see their arms and legs, the muscles aren't going to be as good depending on how long. And you're going to think that, children, and yes, children do get foot drop and they do get muscle atrophy. Now they bounce back quicker than adults, with therapy, but they still go through it. There are skeletal systems, of course, that bone demineralization, so we get weaker bones. And then, of course, it doesn't matter, adult, child. Cardiovascular system, you're going to see, pressure sores and edema and venous stasis, and, you have to turn, and then the lungs and atelectasis and all of those things are going to happen. So we're going to work to prevent those, whether it's good pulmonary toilet, turning, positioning, rubbing, positioning, all of those things are just as important on children as they are on adults. So let's say you're that child who is of age where they're aware of their surroundings, and all of a sudden they have to be put in bed for months, 6 weeks, and they can't move. This is a child who's now immobilized, and if most of the time these conditions means they're stuck in bed on complete bed rest so that their bodies can heal. These children get really angry. They get really frustrated. I mean, if it's just a temporary one, it's not as bad. But what if it's that child who used to walk and be around, and now that child's muscles are degenerating and they're not able to walk and get around and being as mobile? That is the one who's really going to become aggressive and frustrated. And they will regress. They will go in, the younger children start sucking their thumb again, or wanting a bottle, or becoming incontinent when they're potty trained. Now, put a child in the hospital or put a child at home. It doesn't matter who's immobilized. It totally disrupts the family, the mother, the father, the grandma, the grandpa, and the siblings, because now a lot of the time is spent away from home, in the hospital, or if you're home, they're in the room taking care of the child to get the needs met. And trying to get out of the house sometimes requires a lot more organization and time to do it. So these families need a lot of support. They need home care assistance, and they also need some groups of coping. 1 second, my oh, I love husbands. Anyway, so let's keep going. So let's talk about some injuries children get, and this is probably the most common, those traumatic injuries, those falling downs, those sprains, those strains, those bruising that can occur. Usually it's just out playing, walking around, and of course, sports. Children love competition. Now, contusion is basically an ecchymosis. This escape of blood into the tissue, causing this black and blue and purple and yellow and green and yellow and whatever other color it becomes as it goes away thing. Now, be careful. We think just an ecchymosis is not a difficult thing. It's nothing to look at. Well, what about the swelling underneath? Has it occluded any vessels? Has blood flow to the distal extremities be intruded upon? I mean, is the blood flow going? Are there decreased pulses, decreased capillary refill? This is something you always need to look at, especially if it was a crush injury that causes this ecchymosis. You need to evaluate if there was any injuries underneath. Okie dokie. Dislocation. Now, dislocation is when a bone comes out of the socket. It could be a hip bone, it could be a finger, could be a toe, anything, okay? And it's called dislocation. Now, I think the most common of children that I do see is what we call nursemaid elbow. Take the kids and you swing them around and then their elbows pop and then they're hanging their arm by their side. And they just go to the physician or to the doctor and they just take a little tweak and they put it back in. Why does that happen? Well, their tendons are still soft and pliable and that they're able to just put it back in and then be very careful not to hum them around, by their arms again. Because, kids, more, do more. And it can hurt them. Now, Down's children are extremely flexible. They can put both legs behind their head. And you're like, oh my goodness, but be careful. Remember, their hip bones can pop and it could cause a potential loss of blood supply. And that could be very dangerous for loss of limb. Sprains. Most of these are done by traumatic injury. It is for me, it was playing volleyball most of the time. Go up, spike a ball, come down right on the ankle and you can hear it. Or walking on grass and you get into a hole and then your ankle goes. These are extremely painful. You're going to see swelling happen really quick. There could be damage to blood vessels, muscles, nerves, tendons. And this is something that needs treatment of RICE, your rest, ice, contain, and elevate, which is the next slide. We're also going to use that for strain. Now, strain is when you tend to work the same muscles over and over and over again. And there's these little tears in the muscles and the tendons, and it causes pain. And the only way to cure those is rest. And again, RICE, rest, ice, compression, elevate, and then, of course, immobilize it. When I first started in nursing, you got a sprain. And even when I was a kid, they never casted a sprain. But today, depending on the severity of sprain, they might cast it for 2 or 3 weeks just to keep that tendon in good position so that it heals correctly. At least today, they're putting splints and little boots on that can also help with that muscle going and healing the correct way. Now, fractures, totally common. And the most are the hands, the wrist bones, the radial and the ulna. And why? Children fall, people fall. What do? You put your hands out. What happens? You break your wrists, okay? Now, when you have an infant, their muscles, their tendons, their bones, they're really soft and pliable. If we see fractures in an infant, it requires investigation because it takes a lot to fracture their bones. Now I'm going to tell you a story briefly, and I'll never forget this as long as I live. 3-month-old boy came into the emergency room in the mother's arm, complaining of some swelling behind the ear. So brought her into triage where I was, picked the child up underneath the head and the neck and the butt, and I felt my fingers go smush into his head. put it on the scale and weighed it, and the kid cried. So I already knew what was going on. Did my assessment. I couldn't see any bruising or whatever, but I did see this discolored area behind the head. Gave it back to the mother, went into the physician, told him my suspicions, and he says, Betty, go ahead and do an x-ray. If you see there's a fracture on the skull, I want you to take and do what we call a bodygram. An infant can fit on an entire x-ray plate, and that could see arms, legs, ribs, hips, could see. Well, that infant not only had a fractured skull, and it wasn't just fractured, it was depressed and displaced, so it hurt. They had a fractured humerus, fractured ribs at different levels of healing, if you can imagine, and a fractured femur. So definitely child abuse. So as a parent, I wanted to scream, yell, kick, do something to someone that hurt a child. But as a professional nurse, I had to say, what can I do to protect this infant? Well, I needed to report it to the charge nurse. I needed them to call in the authorities, DCF, and to make sure that this was not going to happen again. Well, there was a twin, like I said, right? They called that child in, same injuries. Called in the 2-year-old brother. He was walking around on a fractured femur and had other broken bones at different levels of healing. Well, the end of the story was, it was the father who had to stay home with the kids because the mother had to work because he lost his job, so she was working like crazy. And apparently he was in the bath and the kids wouldn't stop crying, and he picked the kids up and slammed them against the surround in the shower. Now, that is abuse to the maximum. Well, the father is no longer in the picture. He's where he needs to be, in jail, and the mother has the children. So I'm telling you a horrible story, but the point of the story is it's hard to maintain your professional behavior. I could have screamed and yelled, but what would have that done? It wouldn't have done anything good for the child. What was good for the child was to make sure I kept that kid safe, okay? Okay, distal forearm, the most frequently broke bones, and bilateral wrists happen when they brought out those little scooter things for Christmas. They didn't have, handlebars, just scooter, and you push back with your feet. And these children were not in proper gear. And I had 2 that Christmas, bilateral fractured radial and ulnar, both arms, 2 arm casts for Christmas is what they got. And that was due to this vehicle device that they had for motorizing around, wasn't a bike. And of course, sports injuries cause this. Now, there's different sort of fractures you can have. Now, most of them are just simple or closed. There is a break. Sometimes it cracks across, sometimes it's just a simple crack. And they're all different sorts of fractures, and you'll see that on your study guide. You can have many. Now, the open or compound fractured is when the bone sticks through the skin. So now what are you worried about? Now I've got an open access to the air of my bone. So osteomyelitis is one of these big things that can happen. So IV antibiotics, and it will be 4 to 6 weeks to take care of these children. Complicated is when you have fragments that damages organs or tissues. Well, think of rib fractures, what's underneath. And then comminuted is when there's all different shattered bones in the skin around the tissue. Now, the hardest to heal, the one that we take the most care with is what we call growth plate fractures. It's an epiphyseal plate, which is part of the bone that grows as you grow. So if we do not set this correctly, you could have a crooked arm, a shorter leg, a crooked arm. So these do require surgery. They will be an open reduction, internal fixation, and a lot of times they'll put pins in there to keep it solid and keep it straight so that this child's going to grow properly. Usually when we do the surgery and do it that way, there's no long-term effects, but it's those children who have these little fractures that don't get set like that there can be some issues with growth. Now, as I said, infants are very soft, pliable, but look how, unique and resilient they are. The young children, 2 to 3 weeks, you can heal a bone. So if they have, things with bones that we put casts on, they only need the cast for 2 to 3 weeks. Earlier in the childhood, those ages, 2, 3, 4, only needs 4 weeks. And these children heal quickly. And the later ones, as you see more and more, 8 to 12 weeks for adolescents. And, as adults, it could be a lot more because we heal really slow. So you get a kid, can't walk on, let's say can't weight bear on a foot. We know something's going on. Usually sprains they'll try to step on and they'll limp and they'll gimp. But when we're talking about fractures, they will not put their foot on it. So we'll do, of course, an assessment and we'll do a history. Now we'll get the mother, father, whoever brings them, see what they say. And then if we can get the child alone, we're going to ask that child too, how did you break your leg? Only for safety, because it is our job as registered nurses to protect children if you're working pediatrics. Our goal after we get the x-ray, find out we have a fracture, is to reduce it, immobilize it so that the function is restored and that this child will not have a deformed arm, leg, finger, toe, whatever. So put the cast on. This is something we need to teach parents and we as nurses need to know. So the 6 Ps, we need to know if this cast is put on, if the pain becomes worse and worse. Then if we see those, if it's on the arm, the fingers are getting more pale, becoming whiter, or we don't feel any pulses, or it's getting numb and tingly, or they can't move it. And we feel pressure building, this is probably compartmental syndrome. Now that arm, to the right is, the extreme, but I'm telling you, it can happen if they, go off and take off with a cast and, don't come back for treatment. It could happen. Obviously, there's a picture of somebody, so it can happen. So casting fractures in pediatrics is actually, in the hospital I worked at, was a lot of fun. Pick out your colors. It could be holiday colors. It could be, sports team colors or favorite colors. And sometimes we'll even put cast on the dolls that they have. So it's all distraction to make them feel that the cast is not as bad as it really is. You break your arm, you put a cast on, you make it your team colors. It's pretty cool then. So instead of the old white casts. Now, taking care of these casts is important at home. They must be kept clean and dry. I mean, in Florida, one thing that I see, and probably 1 a week minimum, these children get a little fracture on their wrist. They got a below the elbow cast on. They go home, put their bathing suit on and jump in the pool. Well, guess what happens? They got to come back and get a new cast. Now, I'm having thunderstorms. If my internet goes, I want you to know I will try to get back. There's pretty big thunder out there right now. Okay, so cast care. We know to keep it dry now. All right, so we give them bags to put on their cast, the short legs, long arm, short arm, and we teach them how to take a shower or a bath without, getting their cast wet. Also sticking nothing inside, no objects. You could take a hair dryer, cool air, blow it. That sometimes helps. But it's very important that we don't put things in there because it can cause, a tear on the skin and then infection. Now that first page I showed you, that there is traction. Now traction could be either skeletal or it could be skin. Now skin is a Buck's traction because there's no metal in the bones, okay? And most of the time in this thing, what we use it for is a fractured femur. So think about this. Fractured femur is busted all the way across. Both ends are sharp, and now the muscles are pulling those sharp edges into the muscle and the nerves and the tissue, creating a lot of pain. We take them, put them in Buck's traction and stretch it, and now the bones align, waiting for surgery, and then the pain is a lot less. And it helps alleviate pain and muscle spasms, and it really gives that physician opportunity to do a prepared, planned surgery instead of an emergent. So why do we do traction? Well, here's skeletal. I mean, the one on the left is tongs into the head for cervical. It could have been fall, where there was nerve impairment and loss of function of lower extremities. So we do this for fatigue and involved muscles not pulling it, creating more problems. And it does start the healing process. And as soon as a bone is broken, it starts to heal. So we do prevent deformities sometimes and further injury to the surrounding tissue. All sorts of traction that we do have. You know, there is traction, the Bucks traction. Remember that pulley and that weight has to be free hanging. It can't be set on anything 24 hours a day. Bryant or Russell's traction, feet up in the air, hip dysplasia. And then there could be some sort of cervical problem on this child, could be fused something, or there's all different things that actually can happen. And they put these halos on to keep that neck straight. At times, we need to put on something called an external fixation device. And we use this a lot if we have some children born with an arm or leg shorter than the other. They can put these devices on and pull them apart and let this child's arm or leg become the same size as the other one. That can happen. Or there could be bad breaks that have to be put on like this. And these are good. And children walk around and they do well with them. Our concern with these is to look at the pin sites and to monitor for infection and to do pin care. And pin care is as simple as, you know, just soap and water. They used to do all different other things, but again, it's whatever the physician wants the pin care done with. Now, children get amputations or are born without legs, that these children will need to have a prosthesis. Well, if a child was born without a limb, they'll be fit as soon as they're able up and walking with prosthesis. And let me tell you, they do really well. I had a friend's daughter who was born without a fibula, and she had to have the below the knee amputation. I met her at age 4, and she was taking that child was taken off her prosthesis and chasing my children around up and down the house, you know, up and down the stairs, so that they were trying to beat them over the head. So I think that's really amazing how resilient. If it was due to an infection, some sort of other thing that went on and they had to do an amputation, remember there is still that phantom pain, and pain management would be appropriate. Sports injuries, children are so competitive. They want to, you know, win, 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 win. They're going to push themselves to all extents. So make sure that they do have proper equipment, that they're warmed up properly, and that they don't have these overload injuries, that they do learn how to sit down and rest, because sports is great for children with parental supervision, but, you know, they can injure themselves, to be aware of that. Overuse syndromes, well, today, let's say the Olympics, or let's say I want to get into college and I'm going to go on a sports scholarship. You know, these children and adolescents push themselves more than they sometimes should, and they do get these overuse syndromes. So there is, you know, these stress fractures that occur, and the only treatment literally is rest, which, you know, they don't want to do. Now, I did mention hip dysplasia. It's also called developmental dysplasia of the hip, DDH. And this is when the hip socket, the femoral hip socket, doesn't go in the hip socket. It goes up higher in different stages. So if you can see, as I raise my hand up out of that socket, can you imagine that one leg is going to be shorter than the other? So girls are more than boys. So why does that pediatrician on first visit of your newborn infant take those knees up and down and move them back and forth? Well, they're looking for hip dysplasia. They're looking to see if they feel that clicking going, hearing that clicking going on. They're looking at their gluteal folds and their leg folds. They should be equal, not unequal. So, and the shortened limb on one side or the other. So, as I said, infants heal very quickly. So they'll put them just in this skin traction called a Pavlik harness. Now, Pavlik harnesses need to be on for 23 hours a day, and we only take them off for bathing, okay? They have to keep it, their hips and their knees up, which forces those hip sockets, those little balls that go back into the joint. Now, sometimes they don't. Usually they're on anywhere from 2 to 4 months and they do really well. They're not walking it anyway. They're not rolling it anyway. So to get them early is the best. Now, after 6 months, sometimes they have to put them in a spica cast. It's the only way. And older children, those tendons are getting stiff. They're already in that position. We can't get them to move. So that would need surgery. Another thing is club feet. Now, you don't need to know all the different names of inwards, outwards, plantar, dorsiflexion, but just to know club feet is a malformation of the foot and ankle of an infant. Now, we need to correct them because these children are going to have to walk. And if they're out in the wrong way, they're not going to be able to plant their feet and walk correctly. So we're going to do something called a Ponseti method. And if you look, there's just these little casts. Now, these casts are very important. This parent has to come back every week to change them because remember, they heal quickly, right? So to wait for a month or longer is way too long. So every week we change them and we get those feet and those ankles back into the position they're supposed to be. And because they're so pliable and they're so flexible and they heal very quickly, these children do really well. Now, as they grow older, you must continue to take them and be evaluated to make sure that those feet and ankles maintain their straightness, okay? They might need some shoes, different shoes, as they get older, as they start to walk. Now, I mentioned already osteogenesis imperfecta. It's also called OI, and the other name for it is brittle bone disease. That means you can sometimes even touch ribs and you can feel them just by picking them up. Their ribs could crack, or changing a diaper, picking their leg up, a bone could crack. That's how fragile, and you just have to be so tender with these children. So these children are nothing we can do for them. We just do supportive care. And our goal is to keep them in a position where they can sit in a wheelchair. Now, at the hospital I worked at, there was children with OI and they'd be in their electric wheelchairs. And sometimes they only had a couple of fingers that would work to work the electric wheelchair. And they'd be going down the hall going beep, 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 beep. And you knew a kid was coming to move over. And I liked the idea that they were able to have a little bit of, mobility. They could see the world on their own terms, and it's great. Now, what we need to do for them is just, as I said, supportive, IV biphosphonate therapy. They'll get calcium, supplements, vitamin Ds, all of that, but it doesn't really help. It's just maybe it helps a little, okay? Leg calf Perth disease is an aseptic necrosis of a femoral head. That means there's no infection, but the femoral head, that ball joint, is starting to die. So usually these children are males, ages 4 to 8, usually one hip, not the other hip. And what happens is somehow, some way, circulation was cut off to that ball of that joint. So what do we do? Well, once we see that pain, that limp, and we know that this child in the morning is stiffer and all of that, we're going to do that's part of the history. We're going to do an X-ray and possibly an MRI. And what our goal is to keep that femoral head so we don't have to do a total hip replacement, right? So we want that head of the femur, and we're going to put them on bed rest, complete bed rest. And sometimes we'll even put them in that Buck's traction to hold that all in place. All they do is NSAIDs for pain control, and it usually works. So usually bed rest, NSAIDs, they do well with traction sometimes. It might have to go to surgery, but rarely it does. Okay, we're going to go over 3 conditions of the spine. Kyphosis is what we call humpback. It's the upper thoracic spine, and you'll see them humped over. You'll see older women and men, they're humped over their back. Well, their spine has arched like that. Lordosis is when the lumbar curves in, so they're sort of leaning backwards, okay? And then there's scoliosis. And when you think scoliosis, think S-shaped curvature. And usually, you know, they could be born with it, but usually what happens is during that pre-adolescent growth spurt, you're going to see their spine get crooked. And usually you see one shoulder up more than the other one. So one of the things about scoliosis is it is mostly your adolescence. What are adolescents into? Body image, right? Now, they've got to wear a brace 23 hours a day. 23 hours a day, and they're going to go to physical therapy, do strengthening exercises to try to get that back straight. Now, there are severe curvatures that will need surgery, and those will get Harrington rods, where they put these metal rods and clip them to the spine and try to get that spine as straight as possible. Because that S actually, if it gets really bad, will impede upon space of one of the lungs. So now you're talking, there's a respiratory compromise. So try to getting it back a little bit is the best we can do. And they got really neat colored braces now. So it does help these adolescents. Now, osteomyelitis, kids are always out running around without shoes and socks on, you know, and they step on something and, you know, their big toe, it starts to swell. Well, when we see that red, that swelling, and then if it gets bad, they're also going to get a fever that goes along with it. So with that pain and whatnot, they'll be doing a CBC. They're going to see that leukocytosis, white count's going to be off the roof. And then if we can go in and do bone cultures, we're going to find out what bacteria, and we're going to treat it. Now, osteomyelitis is a type of condition where your bone has an infection. If you don't heal it, you're going to get an amputation of whatever that bone is. So as soon as possible, IV antibiotics. And it could be 3-4 weeks up to several months. We need to get rid of that infection. Now, usually the environment, what's the bacteria it has? Staph. What antibiotics take care of staph? Vancomycin, SINs, the aminoglycosides, which means peaks and troughs, and worrying about renal function. And of course, if it's not renal function, monitoring their hearing, because hearing can be affected by that. These children need a good protein diet with carbohydrates in order to help their muscles and their bones heal correctly. Now, Ewing sarcoma is a cancer. We didn't talk about it with cancer, but it is a bone cancer. And it's any bone, femur, tibia, ulnar, vertebrae, pelvis, scapula. Now, if you look at this, this kid has a mandible that's hit, and this little girl has the scapula. So what do we do for this? Radiation, shrink it, chemo, and then try to take it out as much as possible. And we know outcomes always are related to metastasis or no metastasis. Rhabdomyosarcoma is something that comes from the muscles, the tendons, the bursa, the fascia. And we'll see that in the gums, we'll see that in the eyes, we'll see that in the nose, the sinuses, ears, and then you can see it in the perineum, but you'll see them looking like her. I mean, they'll start growing, they'll be a little, they think it's a pimple, and it gets bigger and bigger and bigger. It is highly metastasized, highly malignant, and it does metastasize. So we need to get that tumor out as soon as possible. They need to be on radiation, chemo, and because of how malignant it is, they'll be on long-term chemotherapy. Juvenile idiopathic arthritis, or JRA, whatever you want to call it, is when the own body attacks joints. Usually the onset of juvenile is ages 1 to 3. Many times these kids have a little limp or little stiffness, and it's just minor, and it's just not diagnosed at all. Now, if it gets to the point where they're starting to see those joint swelling and they're limping and they can't walk, and of course it's in the morning, we're going to say, okay, it's possibility. And they also have the one of the things they can get is called uveitis, where we get an inflammation. Now, problem is, let's diagnose JIA. Just like it is in the adult world, it is difficult to diagnose. I mean, I have I have adult rheumatoid arthritis. It's taken them 10 years to diagnose me, and I'm in my second, third, fourth year of trying to figure out what medicines will work. So it is a frustrating disease for children, for adults, for anybody. What you do see is an elevated any inflammatory markers like SED rates or the C-reactive proteins. All of those you'll see elevated. You might see white counts elevated when you're really hurting bad. ANA positive, I've had one positive, negative, RA factors, negative, positive, it all depends. So it's just really hard. But once we've determined, yes, okay, yes, you have rheumatoid arthritis, let's figure out how do we take care of it. Because our goal is to preserve our function and to prevent those deformities and try to relieve the pain that goes along with it. These are managed with NSAIDs, and NSAIDs do work really well on these children. They put them on Humira, Enbrel, Cimzia, one of those type of things, or they can even go into the biologics even more, with infusions. I ended up on infusions and none of the other stuff was working. So let's see if this works. Also, methotrexate is given, which is a chemotherapy, but it is used in rheumatoid arthritis. And corticosteroids are usually used for those really bad times where the pain is really high to decrease that swelling, but they don't like to use it too much. Now, how do we treat this? Well, the biggest thing is to keep up and moving. So physical therapy, occupational therapy, keep that pain down. I mean, for me, put me in a swimming pool, take a child, put them in ballet, put them in some sort of sports that's just not as, active as maybe football, just to keep them stretching and moving and running. You can use heat, you can use cold. Some people like to have the warmth, it feels good. Give me cold, cold feels better, but whatever works and it helps with that pain and discomfort, that's what we do. Because we want those children to be as normal as possible. In any illness with pediatrics, we want the child to still be a child. Lupus, erythematosus, you talk about, autoimmune attacking joints, well, autoimmune attacking body organs, right? Now, lupus is usually girls, ages 10 to 19. We don't know why it occurs. It could be puberty, that hormone imbalance, who knows? It could have been an exposure to drugs, infection, stress, it could be that, or even overexposure to sunlight. Usually you will see these cutaneous lesions like around like this butterfly rash, they call them. Sometimes these children start with nausea, vomiting, diarrhea, and pain, the adolescence. And then they're starting to feel a little discomfort and then all of a sudden forgetful, but then seizures and paralysis. And then they go, all right, let's put this picture together. Pleurisy, pericarditis, and then proteinuria, because now this one is attached kidney. So these are symptoms that we would see. So our goal again, let's keep these kids being kids, right? So we're going to be giving them usually steroids that help these children, a small daily dose. Also, we are going to tell them about sunlight and to protect them with sunscreen and minimal outdoors. So Kirsten is 10 years old, sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider what?
B.
It is a bone growth that can be affected by those fractures. Absolutely. And we know that those bones must be placed in good alignment with an open reduction internal fixation. Good. Okay, let's go into the neuromuscular muscular dysfunction. This is cerebral palsy. Now, what is cerebral palsy? Well, it is a permanent disorder with the development of movements and postures. These children sometimes, they're all different sorts of cerebral palsy. I think when we think of it, we think of that spastic one where they are in this tonic, like always tense mode, and they can't, sit in normal places, sit upright. They can't hold their own spoon, etc., because they're just so tight. Doesn't mean that they're not smart up here, though. Little Jonathan, that I took care of, spastic cerebral palsy, would see me and across the room would start smiling ear to ear, and you'd see his arms coming up because he knew I was going to come kiss him. So do they know you? Oh, yes, they do. Are they smart? Smarter than you think. They just can't express themselves because they don't have the capacity. But they are teaching these children today. Many years ago, I worked with these children in high school, and you just did basic care. You played with them. They didn't teach like they do. So the progression that I have seen in the care of cerebral palsy is totally amazing. Okay, what causes cerebral palsy? Well, it could be an abnormality in the brain, could be a vascular occlusion. That means hypoxic episode because blood didn't get somewhere. Low birth weights are one of the big ones because of the fragility in their brains and brain bleeds, intraventricular hemorrhages, right? So those can cause it, not all the time, okay? That anoxia and then a hypoxic infarction. So, many children are born and there's a delay in their birth due to getting them out, and that hypoxic episode could. Now, I'm not saying it always does, because I've seen miracles occur and I've seen many children do very well with early intervention. So, evaluation. Well, this is why we do all of these assessments. Their fine motor, gross motor skills are all going to be extremely delayed. So that's going to clue you in, and especially if you have that history. So I mentioned spastic cerebral palsy. It's what we call hypertonicity, poor posture, and difficulty maintaining balance. Many of these children will never walk. Some can, depending on how much the severity of the cerebral palsy. So we need to go, when we see cerebral palsy, when there was no clue, to look for that either metabolic or genetic. Sometimes it could be metabolic, and sometimes it was coming from mom or dad. So as I said, delayed gross motor development, abnormal motors, those muscle tones, it could be tense, that they can't relax, abnormal postures, and they're not going to respond to reflexes like anybody else, and they will take extra care. So as soon as we can get early intervention like Jonathan had, speech therapy, occupational therapy, physical therapy, these children can do more than you ever expected. So our goal in these children, now Jonathan is a severe case, okay? There are children with less degrees of cerebral palsy. If we can put braces on them, put them in a trike, let them ride around the room. Can you imagine the freedom that child has? I think it's amazing, and it's good for the mental, because now they have to think of what they're doing. So it makes them think, which I think is great. These children should be put in as regular situations with children as possible, because they do learn and they are smart. So being social is very important, getting them involved with other children. They put them in ankle and foot braces because of hypertonicity, and they don't go the right way. We want to keep those feet in a place, just feet alone, in case we can get them up and get them walking with a walker one day. Maybe they're age 5. Now, if we let those feet go, there's nothing we can do. So braces are done. We also do pharmacological botulism. Jonathan was put on levodopa carbidopa that we use in Parkinson, and it helped stiffness, his tightness, his shaking, those tremors decreased. So this is a great thing that they're using. It's a newer thing that they're doing. And then of course, their mouth, their dental hygiene really needs good care. Now, Jonathan didn't eat. I mean, he couldn't have anything. He was nonverbal, but his mouth always required good care. And of course, therapy, therapy, therapy. So prognosis, well, 85% can achieve ambulation, and they can live to be, quite old with cerebral palsy, mild cerebral palsy, and can go on to live lives by themselves, depending. So with the child who requires more care, these parents really need help, making sure they have the proper equipment, that they know how to work with their children to keep them going and try to make them work on goals, and then make those goals and do more goals that are more, because these children can reach things and do more than they've ever done before. Make sure they know medications, knowing safety. These kids don't need to be falling out of bed or wheelchairs and not using restraints, etc. They need to know that importance. And they need to get up and out of bed. And they need to be in wheelchairs, or they need to be in these recreational and brown people. I mean, I was very blessed working at this PPAC, which is the prescribed medical daycare for children. In the summer, they would take pools, little pools, put them on the outside and let the kids stick their feet in them and splash them, or put their hands in and let them splash. And you should see the smiles on the face. It really makes the child be a child. Okay, neural tube deficits. Have you ever heard of folic acid? And if you don't take it as a mother in pharmacology, neural tube deficits can occur, right? Well, this is what a neural tube deficit is. We're mostly going to talk about the spina bifida myelomeningocele. Those are the ones that we're going to be concerned with. What happens? Well, the back doesn't close up. Like the midline, we've had the stomach on the outside, the bladder on the outside, gastroschisis, bladder exstrophy. Well, now we have myelomeningocele. Well, what it is the sheath, the sheath and the nerves are all on the outside. Okay, spinal cord, all on the outside, the meninges, the spinal cord, and those nerves have been stretched to get there. So, and it's the lower extremity nerve. So you can see how you might have motor deficits or sensation deficits, lower extremities. Also, your urine, they may not feel that they're full, and constipation. All of those things need to be watched. It could be due to maternal obesity, could be due to diabetes or low B12. They say it's that folic acid, but it helps. I would take it, but not everybody knows they're getting pregnant. So how do we treat it? Well, when this child is born, most of the time in the ultrasound, we will see this. So they'll be born on a C-section. We'll get them out. And now remember, this is the insides of them. We need to put a sterile cover on that, okay? To make sure that we protect it. These children will be prone. They'll be on their bellies. Only time you will see an infant on their bellies. And of course, they'll be monitored with a heart monitor and a O2 sat monitor, because we don't want SIDS, right, on our watch. These children are also latex allergy. Many of them require to have catheter every 4 hours because they can't urinate on their own. So we're always introducing latex. So today, no latex. Again, watch their urine, watch their bowels. And as I said, it's all about the folic acid. 0.4 milligrams a month before you get pregnant is what you should have. Or if you're deciding you might want to be pregnant, take a vitamin with it. Okay, let's go on to spinal muscular atrophy. This is a progressive atrophy of muscles, okay? This one is the worst one. This is floppy infant. These children usually die by about 2 years old. It's progressive weakness and wasting of muscle. You try to pull these kids up with the hands and most will pick their head up. These kids are just floppy, and they are just floppy. We'll see it about 2 months old where they're just not lifting their head up. They're just not doing anything. And they have this very weak cry. So these children, Werdig-Hoffman disease, they're usually dead by 2. Thank goodness it's not that common. Now, just like tetralogy of Fallot, I'm telling you, you're going to see Duchenne muscular dystrophy again. Those 2 diagnoses, guaranteed, guaranteed, I'll be on your NCLEX, guaranteed. Now, Duchenne muscular dystrophy, again, is a progressive wasting of muscles. These kids are born fine. They usually are walking fine. And all of a sudden, you'll see changes. It is an X-linked, which means mom carries this. It's males ages 3 to 7, okay? And what you will see in these children is that they'll have this progressive muscle wasting. And then because we have the muscle of the diaphragm, they usually die from respiratory failure. So what is our goal? Because it's usually they get to be adolescents, these children. So during this time that we have them and their muscles are wasting, what do? Well, first of all, we're going to see these children that used to walk are now, they're waddling and they're very gingerly placing their feet. They're going to be falling more than ever. And then when they're on the ground, just like old grandmas like me do, you walk up your legs to stand up because it's easier. These kids do it too. That's called Gower sign, okay? And then that lordosis, curvature of the lumbar spine. And because their muscles wasting, these kids have a tendency to be overweight. And you can imagine overweight, muscles don't working. These children, need physical therapy, occupational therapy, and these children need, not to be as heavy because it's be harder and harder for parents to work with them. There's really no treatment, but because it is a progressive muscle wasting, it is therapy. Therapy, keeping the muscles moving, range of motion, bracing, and then again, that genetic counseling for family. A mother, asking, should she have another child when she just got diagnosed with this kid having muscular dystrophy would be told that the possibility is she could have another one. So genetic counseling is important. Usually the way we diagnose these children is there's this old-fashioned test called EMG, electromyelogram, where they take this little, looks like a heart sticker, that you put on the monitor, and they attach it and put little electrical shocks, and we'll watch the way the muscles respond to it. Now, the one thing, if you have a child going under this EMG, please tell the family that they could come back sore. They are moving muscles they haven't moved in a while with these stimulations. It does hurt. Guillain-Barré, you've seen this in MedSurg too. Guillain-Barré is an ascending demyelinization of the nerves, which means you're going to start seeing the nerves in the legs start to get numb. You're not going to walk, you're going to fall. Then it's going to go up higher. You're going to see them incontinent. You're going to see bowel problems. And then it will get up to the respiratory, which is our concern. And their diaphragm, which is motivated by a phrenic nerve, stops working. So they're paralyzed, literally, from usually the head down. These children usually are those younger 4 to 10, usually after an upper respiratory infection again, okay? So you'll see that tenderness, paresthesia, the weakness, you'll see the going up, and then all of a sudden you're going to see them stop breathing. So these children need respiratory support. They'll be intubated. If it progressed, they're going to need a trach, and they will wait until they start breathing again. And again, it went from feet up, and when it goes away, it goes from up down to the feet again. We're going to give these children intravenous immunoglobulins and might do some plasmapheresis to get rid of some different things that we want to. And it's basically watching their respiratory, and then it's in a mobile child, keeping their muscles moving, physical therapy, splints, and preventing foot drops, et cetera, et cetera, et cetera. Now, you know, you've heard of tetanus and stepping on a nail, and you were wondering what tetanus is, and it's actually a horrible disease. I mean, we do get vaccinated for it. I mean, all of us every 10 years, we get it. As nurses, those hospitals all will require you to have it, you know, so you're always going to get an immunization for it. But let's say this parent decides not to get it, and this child somehow stepped on something or scratched or something, and they got the tetanus into them. And what do we see? Well, tetanus is like all upper, like above the clavicle up. Muscles tense up to the point where it is painful and you can't loosen it up, and it starts to swell. So there goes airway, right? So you will then go, you can't breathe, you can't swallow, laryngospasms, and these children you'll start seeing getting rigid, and it's just complete tightness. So what do we do for these children? Well, these children, we need to get them out of their pain. They will be intubated, put on a muscle relaxant, and paralyzed and sedated, because we have stopped their muscles from moving. Now, if after giving those tetanus toxoid vaccine and giving them, you know, IVIG, hopefully they'll come back. If they're there 4 days, they probably will recover. These children are extremely, extremely, extremely ill. So we'll be giving them those antitoxins. We will be cleaning wherever that cut or wound was, foot, toe, you know, and again, we're going to also, as we have new children coming in and babies, you know, tell the parents that this is a very important immunization. So intensive therapy, we are going to have them monitoring fluid electrolytes, IVIG, and of course, we're going to clean that wound, muscle relaxants, and sedate them. Now, any of you have a grandma when your infant was constipated, say, give them a little honey or a little Cara syrup, it's going to help them stool? Well, don't do it. We don't know how they were canned. We don't know how they were bottled. We don't know if they're sterile, and they could be having this Colostrum botulism bacteria that can really affect children. So you usually, if we've given them, let's say, the honey, like a half a day to a day and a half later, we might start seeing this weakness, dizziness, headache, diplopia, speech difficulties, vomiting. I mean, infants, you're going to see them not being able to breathe, and you're going to see them vomiting, and you're just going to see them just not being themselves, not active, not talking. And you have to bring those kids, hopefully will be brought into, you know, to see the physician or emergency room. It is a progressive, life-threatening respiratory paralysis, which means no airway, you're going to die. So what do we do for this? Well, respiratory support again. IV botulism immunoglobulin is given to these children, and we will continue it till we get that paralysis to stop. Spinal cord injuries. You know, my last stint that I did it the last 10 years in the hospital was in the emergency room, and it is a level 4 trauma center, and I am one of their primary trauma nurses, and I'm an adrenaline junkie, so I love doing it. And these children come in, could be motor vehicle, it could be out riding a bike, hit by a car, sports injuries, birth I usually didn't see, but trauma, or even that car crash, that hyperextension, hyperflexion of the neck could cause injuries of the neck. We might see that. You know, the one that I've seen, sports injury that I won't forget, 16-year-old boy slid into third base, his head hit the knee of the defender, and the whole stand heard a crack. By the time they went to check him, he already had some numbness of his lower extremities. They called in rescue, they airlifted him to me, and now I have him. So what is my goal? He came into the emergency room on a backboard with a neck brace, taped his head to the board. What is my goal? to monitor that neck. This child had a C5, C6, it was angulated fracture of that spine. He had paralysis of the right side and he was decreased on the left side. So this child was this close to be paralyzed from the waist down, okay? So my goal is to monitor that neck and let nobody touch that child so that there would be a wrong movement that could have severed his spinal column. Now, when you have a spinal cord injury, you're going to have orthopedics and neurosurgery. They're going to need CAT scans, MRIs. They're going to need steroids, and we're going to need pain control for these children. And then after we get them all settled, probably surgery to try to straighten out that spine. Now, the end story to that boy, we did an MRI that day, and I brought him to MRI, and I kept charge of that kid. I wouldn't let anybody touch him, move him, not without my count, and I had control of the neck. 2 weeks later, I saw this kid up on the floor. He had his neck surgery the next day. The kid had just a little bit of numbness in the right side, but he was moving well. He was going to therapy. And then 1 year later, he came to see me to tell me thank you. He was walking and doing great. So a nurse can make a difference just by monitoring that neck and making sure nothing more happened. So which one is the progressive infantile spinal muscular atrophy, which is called the floppy infant syndrome, the worst one that can be?
60?
Yes, it is.
The A.
Good job.
No, it's C, not A.
C. Say wording. Yes, it is. Thank you. So a lot of different things here, interesting things. Hope that I gave you enough of my input so you can understand a lot of them. Who wants to win the Cahoots today besides Brent? All right, Sandra's there. How about you, Rosa? Yeah? Oh, look at her. Jillian's going to be there. I know, you're going to fight, both of you. All right, let's go.
I had a storm. I think it's coming. It's thunder really bad. So am I gonna cut the internet? May not.
Okay.
We'll see.
No, I understand because I'm still hearing it around here.
Yeah.
All right, let's get going. Musculoskeletal and neuromuscular dysfunction. Multi-select. What is the priority for a nurse to assess following a cast application? It's everything. You know, we have those 6 Ps. Remember, they're very important for you to remember and to teach parents. Adult children doesn't matter. I mean, a cast is a cast. What should the nurse monitor after a soft tissue injury? So remember, you don't know how deep this soft tissue injury is or the ecchymotic area. Remember, there's vessels and it could occlude blood flow. So neurovascular checks are extremely important on these children. A fracture that penetrates the skin is called. So it's called an open or a compound fracture. This is going to require long-term IV antibiotics to prevent osteomyelitis. What is priority nursing care for a child who fell off the second floor balcony? Priority is the spine, okay? Remember, they've fallen off. We don't know if the spine has been infected, so make sure that we keep that spine immobilized because we don't want children to be paralyzed that don't have to be paralyzed. Principles of managing soft tissue injury include, you have a sprain. What do you need to do? So that's rice. Rest, ice, compress, and elevate. Good. Uh-oh, Jillian's on top. Here we go. Epiphyseal plate fractures in children may do what? Epiphyseal plate, what is that? What does it do? Why are we worried about it? And it's all about bone growth. So again, it's going to be that open reduction, internal fixation to make sure it's in the correct position. Good job. What findings for a patient in skeletal traction includes peripheral vascular impairment? So if you don't have a pulse, there's something going on. And it's those 6 Ps too, right? Paralysis, pallor, all of those things could show something's going on, and you need to alert the physician on that. How should the nurse care for the skeletal traction for a child with a fractured femur? I mean, sometimes they do skeletal traction with a pin. Sometimes they'll do the bucks traction, which is a skin traction. But we do the same thing for either or. It doesn't matter. And the only thing that we need to do with it is to make sure that those weights are hanging freely, no obstructions. And we will document on our nurse's notes how much weight is on and that it's freely hanging. When caring for a 9-year-old in bucks traction, what action by the nurse is correct? Well, if you're in bucks traction, you probably have a fractured femur because you want to pull those bones out to decrease pain, right? So it's absolutely, we're going to check those capillary refills because who knows, it could have slipped the bones. We could have some sort of impairment. So capillary refill is very important. I used to go in and always touch the toes. A multi-select. Which assessment indicates an infant has developmental dysplasia of the hip? Which ones was it? Okay, moral reflex is like a startle reflex. So that's as an infant, okay? Babinski, we know it's the foot. Adult children don't matter, just checking reflex. It's the positive ortolani and the asymmetrical leg folds, could be the shorter leg. Those are things that you will see. Good. Which statement by parents indicates more teaching is needed regarding a 2-month-old infant with a club feet? I mean, we're going to use a Ponseti casting method. I mean, that's really the one that's most commonly used. Rarely need surgery because they're just so flexible. But the one thing that needs more teaching is that they need to come every week, not every month. Every month is too long, and that maybe those now that ankle and that foot is going to be, in a position that's not correct. Remember, they heal within 2 to 3 weeks. So every week they have to have those casts change. A multi-select. Osteogenesis imperfecta. What is that? And it's called brittle bone disease. And it is a genetic problem that can occur. So again, if you have an OI baby, this is one that genetics is going to have to be done for these families. Regressive physical therapy is going to break every bone in the child's body. We will not do any physical therapy on this child. This is that case where physical therapy is not done. One, can osteogenesis imperfecta be the most life-threatening? Well, osteogenesis imperfecta is all about brittle bones. So when's that challenged the most? You gotta think of it that way. And it's during birth, especially if they don't know it's coming. It's not always found out before the child's born. So you're taking a body that has brittle bones, putting it through the birth canal, and you're, crushing it. So can you imagine how many bones could be crushed during that birth? So that is when it's the hardest. And you're pulling on the head and the neck too, right? What is pathological cause of leg calf purse disease? So leg calf purse is an aseptic necrosis of the femoral head, which means some blood supply not getting to that ball of that socket in the femur, and it will completely disintegrate if we don't stop it. So we need to put these children on bed rest. We need to give them book traction, and these children will maybe get NSAIDs only for pain. And it does work, but it's going to take 4 or 6 weeks, it could be. What's kyphosis? And that's the thoracic spine. That's the humpback. Lordosis is, and this is what Duchenne muscular dystrophy children can have. And that's that inward curve of the lumbar spine. And scoliosis, those 3 spine things. Put them all in one at one time. What are they? What did I tell you to remember about scoliosis? Yeah, yes, Jillian. It's that S-shaped curve, yes. And you'll see that one shoulder up either way. Yes, good job. Adolescents with scoliosis that have a 25% curvature of spine would need to do what? I mean, we know there's two different ways that we can treat scoliosis, depending on the percentage of curvature. So 25% does not need surgery. It's brace 23 hours a day, only off for bathing. And not just the brace, it's going to be that physical therapy. It's also need to strengthen those muscles so we can get that spine back to where it needs to be. Here we go. What is osteomyelitis? And it's basically an inflammation of a bone. It's an infection and it is dangerous. It needs to be treated or else you're going to lose the foot, the leg, the finger, the arm, whatever. Juvenile rheumatoid arthritis, or JIA, is what? It's basically an inflammatory disorder of the synovial joints. The body attacks the joints. It says, let me go get them today. Goals for juvenile idiopathic arthritis include what? I mean, we know we want all kids with any condition to be as normal as they possibly can. That's always there. But how do we do that? And that's just reducing the joint pain and swelling. You do that, and the kid can be that child up and out and moving. Systemic lupus erythematosus is what? And it's autoimmune. And again, the body is attacking itself. So we have to calm down that immune system. So multi-select. What can help a child with lupus erythematosus prevent exacerbations? So wearing sunscreen, decrease in exposure, absolutely, because we know just sunlight can, make a flare. And then they will be getting those prophylactic antibiotic steroids before procedures like dental extractions. What organs can lupus affect? Anything, everything, doesn't matter. Attacks itself. What is cerebral palsy? So it affects the body movement and muscle coordination. It's basically an overall global definition for it. It just affects the way you move. A myelomeningocele. What is it? It's that other thing that the body didn't close up right. And it's a hernia of the spinal cord and the meninges. Comes up into the sac. Again, remember, when that pulls out, it's stretching nerves, and it could cause problems with sensation, motor lower extremities, urinary problems, and problems with bowels. So those are things that we as nurses need to monitor close. Infants with myelomeningocele demonstrate what? Motor and sensory impairments because those nerves have been stretched going on the outside of the lower back. Very good. Due to the decreased motor and sensations to the lower extremities, what must a nurse monitor closely? You know, and it's that urinary retention is the big thing. Absolutely the biggest thing is urinary retention. You know, this one little girl, myelomeningocele, was that child that my students all got to catheterize. It was that, you know, easy one to do that they could perform the task easy and actually do a catheterization to a patient. Urinary retention is the big thing there. Foot drop, that's why we're going to wear splints. A key feature of Duchenne muscular dystrophy is what? What is this, Duchenne? And it's just the muscles, you know, you're born okay, the muscles are working, you're turning over, flipping, gross motor, fine, and all of a sudden about age 3, you start to see this kid falling down and you start seeing the wasting of muscles, etc. What is one of the procedures that a child with possible Duchenne's may need to diagnose this condition? And it's that EMG, electromyography. And what they do is with those little, you know, cardiac monitor tabs is what they are. They put electricity in them and they shoot it into the muscle to see how long it takes to respond. If it responds, to see how much wasting is there. And I'm telling you, I've had one many years ago. And even a normal person, I was uncomfortable afterward. I felt like cramps in my arms and my legs. She's after you. How is Duchenne muscular dystrophy inherited? It comes from mom, remember, you know, and mom at this point feels guilty. And then of course, mom wants another child. So again, genetics needs to be done prior to having another child because it does come from mom. Brent's after you, Jillian. In caring for a patient with Guillain-Barré, the priority concern is, I mean, there's so many things that go on. But the biggest thing is airway. So if we had a child or adult admitted with possible Guillain-Barré, you can be guaranteed minimum they're going to have on a saturation monitor because we want to make sure that they're breathing at all times. For a patient suffering with Guillain-Barré, they would complain of weakness that was what? And it's ascending, which means it goes from the feet and it comes up. Descending is going from the head down. Good job. A multi-select. Treatment for Guillain-Barré include what? So many students put down antibiotics. It is not an infection. It is after an upper respiratory viral condition that it occurs. And we give them IVIG sometimes steroids, but IVIG is that case. And of course, any respiratory support, which would be ventilation, because they have no phrenic nerve. They're not breathing. Their diaphragms don't work. What type of cerebral palsy causes hypertonicity and poor fine motor skills? And it's called spastic cerebral palsy. As I said, probably the one that you think of when you think cerebral palsy. You think of my kid Jonathan. It's that little tightness, and you can really see that they really have a hard time controlling their muscles. Spastic cerebral palsy. What priority action should a nurse take to a patient with a suspected spinal cord injury? Priority action. And again, nothing else matters if we sever that spinal cord. That spine is your priority. I mean, yes, you're going to be monitoring respirations and all of that, but you can have all of those things and then sever the spinal column, and now, you're not breathing and you now have a paralyzed patient. So that's spine number one. How you should get a tetanus shot every what years? I mean, years ago it was 5, and now it's at 10. And they're also putting diphtheria with tetanus now. So it's tetanus and diphtheria. And they started that several years back. They felt that it was a good thing to do. So they're always changing, always doing different things. 2 more questions. What is a symptom of tetanus? Remember, tetanus is that, from the clavicles up, tightness of the muscles, and it spasms, and it's so tight that it's painful. And it's called, the other name is lockjaw. Treatment, tetanus toxoid. And last question. Most common causes of spinal cord injuries are what? And it's accidents. Usually, motor vehicle, that's number one injuries for all types of children. And then, of course, sports. Children, love sports, and they're going to slide into third base because they want to win. And then remember, now adolescents are driving, so that is part of it. So here we go. Let's see, number 3. Sandra, good job, Sandra. You said you wanted to win. You did good. But then you have Brent, number 2, and again, you two fighting Jillian. Good job. Number 4, Hannah and Cody. Good job, guys. Those guys going to fight every week. I love the competition. I think it's great. So what I want you all to do is sign your attendance attestations. Remember, if you are one of those who have a project that's not, up in the 90s, go back and look at it. You probably can get more points. I would leave a message if you have that ability. So if you can get points, I want you to have them, and you only have till Sunday, okay? The other thing is, let me know you've resubmitted. Or I have 75 students. I don't know, 75 students who has sent it back or not. So thank you, guys. Remember, next week is your exam. I am doing 2 p.m. tomorrow. I'm doing my review. You will get that as soon as I can get it. I'll try to get it in by Friday evening, which is, not the next day. So I'll get it to you quick, and you'll have all of your Kahoots listed below that. So everything in one place. And then when Professor Okorafor puts hers, I will insert it in the same announcements to have it there. So I will see you next week. Last class with me, guys, next week. And I'm going to do a HESI review after class. And I do it with a Kahoots. Go figure, okay? And it's a great Kahoot. So, and I just remade it last semester. I'm going to look at it again to be sure I haven't missed anything, any new concepts. So you guys should do phenomenal on your HESI. I had, I think, 599.99s last semester. So you too, Brent, can get it. You too, Jessica, Ashley, Sandra, and I'll see you next Wednesday, Tuesday, Ashley. See you guys.
Bye.